Hi, and welcome to Ask the C Patient regarding rash. My name's Sandeep and I'll be presenting this teaching session. So, doctor, can you come to review this rash? You've been asked by one of the nursing staff to come and review a patient who's got a presentation of a rash. What are the first sort of things that you need to ask the nursing staff? Well, the first thing you should ask is, when did this rash start? Is it a new thing or has it been there before and it's gotten worse? Are there any associated symptoms? Particularly, is it itchy or is the area red? Next, are they systemically well? How's their breathing? Are they confused? After this, you should ask the nursing staff to do a few things. One of the first things that they need to do is a set of observations, including SATs and a temperature. Next, ask them to look at the tongue or the lips. Is there any evidence of swelling? Now, these two are important because you need to identify whether the patient's systemically unwell, but also if there are any signs of anaphylaxis, and that will affect how urgently you review the patient. So I'm going to run through an A to E assessment of a patient with a non-specific rash and the sort of differentials that you should go through in your mind when you're looking for signs. So we'll start off with airway. You're looking for any compromise of the airway. If there's any tongue swelling or any lip swelling, this could be in keeping with angioedema and anaphylaxis. So this is a good example here of a very swollen tongue. Next, breathing. Listen out for crackles. Crackles can be present in manner of diseases. Sepsis. Could this be a drug reaction from treatment of a lower respiratory tract infection? Could this be a pneumonia linked to chickenpox or measles? Could this be sarcoid? Then you've got wheeze and reduced air entry. Think about things like anaphylaxis, particularly if it's an urticarial rash. Then tachypnea is something that you might see in sepsis. Moving on to C, circulation. Look out for a raised JVP. If it's a vasculitic rash that you go on to see, this could be causing heart failure. Are there any dry mucous membranes or cold peripheries? Is the cap refill time more than 2? This can all be in keeping with hypotension and shock, and again, seen most commonly in sepsis. One particular type of sepsis that you're worried about when you have a rash is this meningococcal sepsis. Next, you might hear a murmur. Is this a new murmur or is this something that's been present before? Particularly if it's a new murmur, skin manifestations of murmurs could be due to infective endocarditis, an aortic thrombus, or abscess. These can look like Janeway lesions or splinter hemorrhages. And monitor the urine output. If it's reduced, this could be a sign of vasculitis. Peripheral edema can be a sign of lots of things. One of the things that you are worried about, that if it's localized, particularly to one limb or one area, is necrotizing fasciitis. We move on to D, disability. There's lots of reasons to check the blood glucose, and there are lots of skin manifestations of diabetes. You want to look at the GCS and the alertness. The GCS being low and them being confused can be a poor sign in meningococcal sepsis. If they're confused, this can also occur in anaphylaxis. And then you've got exposure or everything else. Temperature is the most important thing to check. Specifically, we're worried about sepsis, cellulitis, necrotizing fasciitis. Look for evidence of injury or trauma to the skin. Is this precipitating a cellulitis in that area? Look for ecchymoses. These would be in keeping with an underlying diagnosis of vasculitis. Is there any evidence of excoriation? Has a patient been scratching? Particularly in an absence of a rash, excoriation might indicate pruritus, associated with chronic kidney disease or liver failure. Palpate for lymphadenopathy. Again, most likely seen in infection, cellulitis, and also palpate for crepitus around the rash. Crepitus is a sign of necrotizing fasciitis, and it's not common. Just speaking briefly about exposing skin, I'm just going to go through some specific examples or areas that might lead to specific diagnoses or indicate that somebody is more susceptible to a specific type of infection. So look at the eyebrows and the hairline. If there is flaking or dandruff present, then you know this patient is prone to getting fungal infections, seborrheic dermatitis. Look at the sclera. If it's jaundiced, perhaps this pruritus is a manifestation of chronic liver disease. Look around the mouth. Is there any mucosal involvement? Are there any ulcers? Could these be Koplik spots, or could this be mucosal involvement in either a drug reaction or Pemphigus vulgaris? Is the rash limited to the periorbital area, particularly if there's associated weight loss? Is this a heliotrope rash? Could this be dermatomyositis? If there's leg swelling present and there are varicose veins, then one of the things that you could be concerned about is venous eczema. Are there any abdominal signs, any hepatomegaly, any spider nevi, any telangiectasia that could indicate that this person has liver disease or kidney disease? Look at the nails. This is a nice example of pitting. Ask about psoriatic arthropathy. Often the arthropathy, the arthritis, precedes the skin changes. Are the symptoms bilateral or unilateral? Bilateral symptoms often indicate a systemic cause. Unilateral often indicate a local cause. Is there a dermatomal distribution? Does the rash not cross the midline? Could this be shingles? Is the rash seen predominantly in skin folds around the groin, in the axilla? Could this be a fungal infection? And is the rash limited to the palm? Are there vesicles on the palms? Could this be Pemphigus? I just want to talk through some of the terminology that's used to describe rashes, because often certain terms aren't well understood. So first, urticaria. So this is a good example here of an urticarial rash. These sort of raised erythematous wheals. You can see the redness here. One thing to note is that erythema looks different on different colored skin. So on Caucasian skin, this typical redness is present, but on Asian or black skin, you can see the erythema actually looks quite dark, quite brown. Next, you've got these vesicles, these small, few millimeter filled, so fluid filled blisters. And then you've got the larger version, which is bulla. So vesicles you'll often see in Pemphigus, you'll see in shingles. And then you've got bulla, which are the large fluid filled blisters, often seen in Bullous pemphigoid or Pemphigus vulgaris. And then you want to look for signs of excoriation. So this is a nice example of excoriated skin, skin that's been scratched and traumatized as a result. And note sometimes that the excoriations occur in the absence of an obvious rash. So someone is scratching the skin because it's itchy rather than there's a rash or a local pathology. Look for lichenification. So this skin is quite lichenified, quite hardened from chronic trauma, from chronic scratching. So it becomes quite dry and rubbery. Look for crusting. So particularly with any Staph aureus infections, an easy way to remember is that aureus comes from the word gold, like AU on the as a chemical symbol. And impetigo often comes with that sort of typical golden crusting. And then lastly, you've got this sort of raised, pedunculated appearance that you see often with warts. So going to the history, what sort of things do you need to ask your patient? You need to ask them about the presentation. Is this the first time that they've had this sort of rash come up, or has something similar happened before? If something similar has happened, has it changed since then? Has it gotten worse? Has it gotten better in between? Did it go away completely? Did it go away on its own? Did they need any intervention? Also, if they've had it before, was it in the same place or was it somewhere else? You must work out what the exacerbating or preceding events were. So have they recently been started on any medication? We'll talk through medications that cause certain rashes soon. Have they recently ingested any food? Have they been infected recently? Perhaps they've had a viral infection, is this a viral exanthem, a viral manifestation, or have they recently had a dose of a course of antibiotics, which have possibly caused this from an underlying chest infection? Have they been bitten, particularly if they've been walking in the English countryside? Have they had a lot of sun exposure? Have they had sunburn? Or if they've not been sunburnt, but they've been in the sun recently, could this be a polymorphic light eruption or an underlying porphyria that's been exacerbated? Have they had recent topical treatment or some sort of topical procedure like a peel recently started on isotretinoin that's causing significant peeling? Could they be pregnant? There's lots of manifestations in the skin from pregnancy, lots of eruptions that can occur. Is there any dryness that's caused this? Or have they recently got a new pet? Do they have any jewelry in the area? Have they recently had an operation? These sort of questions you need to ask to work out what might have caused this or at least made it worse. If the rash is itchy, then it's less likely to be a drug reaction. If it's not itchy and they've got an obvious sort of target lesion, it's more likely for it to be a drug reaction. Is there any pain associated with it? Any neuralgia or sort of burning? Are there any systemic features? Do they have any fever or muscle aches? Fever, particularly you're worried about sepsis. Muscle aches, if they've got any weight loss, you might be worried about dermatomyositis, which is a paraneoplastic syndrome. Do they have any headaches or neck stiffness, any photophobia, anything that might be in keeping with meningitis or meningococcal sepsis? So then you've got relieving factors. Do they find that the rash gets better with steroids or antihistamines? Have they had a gluten-free diet, which has helped? Do they find antibiotics or antifungals have helped, or keeping it dry, wearing gloves? Do they find that their symptoms are better on the weekend when they're not at work, or when they're out of the sun, or wearing SPF? SPF often improves appearances of things like rosacea. And then the past medical history, you want to work out if they have a cardiac history, if they have any hypertension, could this be a manifestation of thyroid disease or the many sort of skin changes associated with diabetes? There's lots of drug causes for rash. Erythema multiforme is one of the conditions that can occur from drugs, so penicillin, sulfonamides like trimethoprim, carbamazepine, got NSAIDs, the pill. And then you can get odd reactions from vaccines. Immunosuppressants can often put you at risk of developing fungal infections, just like diabetes can. Tetracycline and amiodarone and isotretinoin, often worse in the sun, so it's important to wear SPF or avoid the sun. Isotretinoin can often cause significant peeling, like I mentioned before. Then ask them about their social history. What's their job? Do they often work with irritants, particularly if they're in the NHS and they're washing their hands quite a lot? Do they have pets at home? Are they allergic to pet dander? Have they been in contact with anyone recently who's had perhaps chickenpox or measles? The tests that you need to order for patients, you're going to do a generic set of bloods usually for a patient that's unwell. Particularly if they're systemically unwell, you might be worried about infection. So you're going to check their FBC, their white cells, check their CRP. Another thing you can check on the FBC is whether their hemoglobin is high. So could this be polycythemia rubra vera? Look at their TFTs. Do they have thyroid disease? If you're worried about anaphylaxis, you would want to do a mast cell tryptase. If you're worried about dermatomyositis, you would want to do a creatine kinase. Vasculitis would warrant an autoimmune screen, including an ANA, an ANCA, an ENA. You want to check the LFTs and the Usenes, particularly if there's pruritus in the absence of a rash. And then if they're septic, You want to check the clotting. Clotting can often be deranged, particularly in meningococcal sepsis. Again, with sepsis, you want to check for a raised lactate. You may want to order a chest X-ray if there are signs on your auscultation of the chest. So if there's a rash in keeping with erythema nodosum, you want to do a chest X-ray to look for hilar lymphadenopathy, which is quite obvious on this chest X-ray. Any signs of fibrosis that might be also in keeping with sarcoid. You want to look for consolidation, particularly if there are unilateral crackles. This can be present in measles or varicella pneumonias. If there's any signs of liver disease or kidney disease, if the USNEs or other LFTs are deranged, then you might want to consider an ultrasound. And then generic sort of skin testing, if you're worried this might be an allergy, then a skin patch test could be arranged as an outpatient. One of the things you have to be wary of is the patient on any topical or oral steroids, or do they have any underlying dermatitis, because that would affect the results. And if there's any evidence of infection locally, then skin swab or scraping, blood cultures. And often if the underlying diagnosis is unclear, a biopsy might be considered. One of the most common causes for skin rashes is dermatitis. There's lots of different types of dermatitis. So you have atopic dermatitis, which has that sort of triad of hay fever, asthma, eczema. Then you have irritant dermatitis. This can be as a result of contact with soap or with some sort of, it can be biological washing powder. It can be, hospital bedding, for example, might be washed in a separate type of detergent. Often it's on the wrists and on the hands, which are in contact. So this is sort of, often what it looks like. And you've got contact dermatitis from things like nickel. So this is a nice example of a patient wearing a nickel ring. This is often, dermatitis is often associated with pruritus, particularly in the flexors. So you can see here in the sort of wrist area, and it's raised, erythematous, maculopapular rash. It's usually lichenified and excoriated. So lichenification, like I mentioned before, the sort of hardening of the skin, excoriation. It's quite evidently been scratched. And the treatment essentially varies. Initially, topical emollients, things like hydromal, diprobase, moving on to topical steroids if needed. You start off with hydrocortisone, then you've got Umavate, Betnavate, Dermavate if needed. Oral steroids can sometimes be used. Working out what the environmental triggers are, particularly reducing heat, whether that's from the radiators or just making sure that patients keep themselves cool in hot weather. Sweating often triggers dermatitis. Use of sedating antihistamines at nighttime, like Piriton, chlorphenamine. Use of wet wraps and cool showers to keep the skin calm. What can often come with dermatitis is that it can get infected, particularly if it's poorly controlled. So there's two types of infection that are common. You've got eczema herpeticum over here, which is like a vesicular rash. It sort of can occur on pre-existing eczema. And then you've got staphylococcus, very obvious sort of golden crusting, although you can't see in this image very well, that's present from Staph aureus. And essentially both warrant admission and IV antivirals or antibiotics. Let's talk about anaphylaxis. I'm sure you all know how to treat this by now, but if we look at the manifestation of anaphylaxis, urticaria can often be the first sign. So this is a nice example of urticaria or wheals that have come up from a patient. Other first initial signs can be flushing, abdominal pain, stridor, vomiting. You want to make sure that they've got oxygen on. You want to make sure that we establish the cause, particularly if it's an antibiotic like penicillin. Is the penicillin still running? You want to make sure that that's stopped. You won't believe the number of patients who are allergic to penicillin, but they have been found to be allergic to penicillin, but no one's thought to take it down. So you want to make sure that you establish the cause and you stop the cause. If it's a particular food, you want to make sure it's out of the room, open the windows. If your patient doesn't have mild symptoms, then adrenaline IM should be administered. But if they've got perhaps milder symptoms and you're not sure, you want to give them some IV fluid, make sure it's crystalloid, not colloid, because that can also cause anaphylaxis. Give them some salbutamol nebulizers, and then hydrocortisone, chlorphenamine, usually for those patients initially that you're thinking more milder symptoms. But if they're not mild, they ought to have adrenaline first. In terms of investigations, you want to do a mast cell tryptase to confirm the diagnosis of anaphylaxis. You want this at both 0 hours and then somewhere between 6 and 24 hours. In that period of time, you want to make sure that the patient's monitored and they don't have a reactive sort of repeat sort of anaphylaxis 12 hours later, which can often occur. Briefly talking about meningococcal sepsis, it's important to know that you can get meningococcal sepsis without meningitis. But often it's important to look for meningism or photophobia because you can get them together. The patient needs a stat 4 grams of IV ceftriaxone. The quicker the antibiotics administered, the lower the mortality rate with meningococcal sepsis. Check your local guidelines because sometimes this can vary. It's a notifiable disease, so you must get onto Public Health England once you've stabilised the patient. And unlike meningitis, where one uses steroids, steroids are contraindicated in meningococcal sepsis. There's a high mortality rate and there's a high rate of limb loss. Shingles can often present in hospital. Sometimes it looks like normal skin that's painful. This then moves on to sort of erythematous rash, moving on to a pustular rash like this, full of vesicles, and then it becomes crusted. And that usually takes 7 days from beginning of the erythematous rash up to the crusting. It's usually quite evident if somebody has shingles, they don't cross the midline, it's in that dermatomal sort of pattern, distribution. But if the diagnosis is unclear, then you might require a viral PCR. These days, we like to treat patients with shingles, particularly if they're in this subset of patients, if they're over 50, and they've got a non-truncal rash with moderate or severe pain or rash. And the acyclovir must be started within 3 days of the rash starting. And the reason for this is that treating shingles in this group of patients reduces the risk of post-hepatic neuralgia, which is very difficult to treat later on. And in terms of analgesia to treat the shingles, you want to start off with paracetamol and follow the WHO pain ladder. Vasculitis, this is a nice example of vasculitis here. It's very palpable, purpura. You can get ulcers, you can get telangiectasia. Usually vasculitis or vasculitic rashes affect the lower limbs bilaterally because it's a systemic process. And there's usually some evidence of end organ damage. So you're looking for signs of pneumonitis, when you listen to the lungs, possibly heart failure, and also reduced urine output could be an indication that the kidneys are affected. You want to do a vasculitic screen or an autoimmune screen, as mentioned earlier. Necrotizing fasciitis is very important, particularly if you're worried that this patient might have cellulitis. It's very important because patients can rapidly deteriorate. There can be certain triggers for necrotizing fasciitis, so it might occur at the site of an operation. It might occur where there's been a skin break or trauma, but unfortunately, most of the cases of necrotizing fasciitis occur in patients who have no skin break. There are 2 groups of bugs that can cause necrotizing fasciitis. First group is usually a mixed sort of group of anaerobes and aerobes. We've got lots of odd names, and this is the most common. And it's most commonly seen within post-op patients, diabetic patients. And the second type, or the second sort of bug that can cause it, is strep pyogenes. Less common, but more of a specific bug rather than a group. The most common site is the perineum. So you may have heard of Fournier's gangrene. This is very common in patients who have SGLT2 inhibitors prescribed. So in diabetics, they essentially lose the glucose from the blood through the urine, which creates a nice substrate, if you like, for bacteria to grow from. Different risk factors, I've talked about them before, but diabetics are greatly at risk from developing necrotizing fasciitis. If you're immunosuppressed, then much like diabetics, you're more likely to be affected by those bacteria. And if you're an IBDU, it's important to monitor a patient that you think might be developing or could have necrotizing fasciitis. You think they've got cellulitis that might be potentially developing into this. The way to do that is to monitor the erythematous edge. So you may have seen patients with a marker around the erythema, and it's important to do that quite regularly at the beginning, so perhaps every 15 to 30 minutes, to make sure that it's not rapidly spreading. One of the signs in necrotizing fasciitis is that the pain that the patient is experiencing is quite significant and not in keeping with the presentation. So often they might have a very mild erythematous area, but it is extremely painful and they may not let you touch it. The most important thing that you need to do for a patient that you think might have necrotizing fasciitis is to get an urgent surgical review. This is to work out if the patient needs debridement as soon as possible. The second most important thing would be to start IV tazocin and clindamycin, or whatever your local guidelines suggest. There is a very high life and limb loss associated with necrotizing fasciitis, between something like 20 and 25%. Drugs can often result in rashes. Most commonly, you get this sort of target lesion here called erythema multiforme. And there's a spectrum that sort of starts with erythema multiforme and crosses over with Stevens-Johnson syndrome and toxic epidermal necrolysis. So erythema multiforme is usually without any systemic symptoms, but once they do develop those symptoms, they start that transition into Stevens-Johnson syndrome. So patients could be prescribed drugs within the last 1 to 4 weeks. These drugs, the drugs that most commonly lead to Stevens-Johnson syndrome, are penicillins, sulfonamides, various antiepileptics, allopurinol, NSAIDs, and the pill. So there's a large group of patients that could be affected. And they start off with these maculopapular target lesions, as seen in erythema multiforme, but then they progress to these blistering mucosal ulcers. The treatment for this, the Stevens-Johnson syndrome, is usually supportive. They need some IV fluids. Toxic epidermal necrolysis, however, can be more severe. So they'll have this scalded skin appearance. They've also got something called Nikolsky sign, which is putting very mild lateral pressure on these on the skin can cause sort of epidermal separation here. And the list of drugs that cause TEN is very similar to SJS. The treatment, however, is a bit more intense. So again, you want to give them IV fluid supportive care, but often these patients need to go to ITU. They'll be on a cocktail of immunosuppressants from cyclophosphamide, plasmapheresis, and IVIG. Some common conditions that you might see in elderly patients, particularly those who are immunocompromised or diabetic, are bullous pemphigoid and pemphigus vulgaris. Bullous pemphigoid, what you need to know is there's no mucosal involvement, or at least for exams, there's no mucosal involvement. Sometimes they can cross over symptoms. Pemphigus vulgaris, there is mucosal involvement, like you see here. And often it's seen in Ashkenazi Jews, so that population is more prevalent, it's more prevalent there. The treatment for both is very similar. They'll need oral steroids, plus or minus immunosuppressants if they don't work. You need to contact dermatology because it's more than likely that they'll need a biopsy. But the good thing is these patients tend to heal without scarring. Now, there's lots of conditions that can present as skin disease, and I can't go through all of them, but just a few others just bear in mind when you're reviewing rashes. So one of the ones that you need to worry about is measles. This can start with a rash on the face, a maculopapular rash spreading to the neck and the rest of the body. Often these patients can have coplik spots, these sort of white-grey spots on the buccal mucosa. These tend to appear around 3 days before the rash on the body and the face. These patients need PCR swabs if you're thinking that they might have measles. And there's lots of complications of developing measles, which is why everybody's so hot on making sure children are vaccinated. You can get complications up to decades later. So the most common one that we know about is pneumonia or pneumonitis, but you can also get panencephalitis from measles up to 10 years later. Another common cause of a maculopapular rash in a patient on the ward is a viral illness, flu or sort of, any sort of coryzal gastroenteritis or any sort of virus that you just normally would let them run its course in an immunocompetent patient. You usually see the rash resolve soon after. Fungal infections, so we spoke earlier about intertrigo and other types of fungal infections, tinea. Well, this is a good example of intertrigo, and I think of breast fold. And you will often see fungal infections, sometimes candida, thrush, and they'll need either oral or topical antifungals plus or minus steroids. You can also get patients who've got drug-induced lupus. Well, thank you for listening to this talk. Please click on the link below to give us some feedback to keep these sessions running, especially if you find them helpful. If you don't, please tell us how we can improve. Thank you.